Bismillahirrahmanirrahim. This is another very important area regarding the occupational health. The area is management of needle stick injuries and body fluid exposures of healthcare providers during their work. Occupational exposure from contaminated shops account for largest number of healthcare worker exposure to blood-borne pathogens. Percutaneous injuries continue to pose the greatest occupational risk for transmitting HIV, hepatitis B and C, and other blood-borne pathogens. A comprehensive approach to reducing the exposure to the blood and body fluid includes the use of standard precautions, use of PPEs, safe disposal of shops, and training and education of healthcare providers. Sharps contaminated with blood, tissue, and body fluids and untreated microbiology waste require special handling and treatment. Occupational risk for transmission of hepatitis B exposure. Studies revealed that the risk of developing serological evidence of hepatitis B infection if blood was both hepatitis B surface antigen positive and hepatitis B E antigen was positive, the risk was about 37 to 62%. If hepatitis B is positive and hepatitis E antigen is negative, then definitely this risk is relatively low, that is 23 to 37%. The risk for occupational transmission of hepatitis C virus and HIV virus is relatively low than the hepatitis B virus. The average incidence of anti-HCV positivity after hepatitis C exposure is about 1.8%, while in case of HIV, the incidence is around 0.3%. Now, I would like to present you some case report. A staff nurse, while working during his shift duty, he was accidentally injured by the needle sharp. She was offered the PPEs for HIV, but he refused. After, in the follow-up checkup, she knew that he had contracted both hepatitis C and HIV due to this needle stick injury. Now, I want to define some important terminology before actually going to the management of these exposures. Immune to hepatitis B virus, it is defined as the patient has the documented anti-HBs level more than 10 international unit per ml after completion of hepatitis B vaccine course. Non-responder, a healthcare provider is defined as a non-responder when the anti-HBs titer is less than 10 or negative after a full course of hepatitis B vaccine. Unknown hepatitis B virus status when their results are not available about the hepatitis B virus serology, then it will be called as a unknown hepatitis B virus status. Some important keynotes regarding the management of hepatitis B and C exposures. All percutaneous injuries and mucocutaneous exposures must be reported. This is must. We should furnish an incident report about such injuries, and we should timely write this report and submit to the concerned authorities. Hepatitis B prophylaxis, when indicated, should be initiated within 48 hours of exposure incident and no later than 7 days. It is the responsibility of all employees at risk of exposure to blood or body fluid to secure receipt of our full course of hepatitis B vaccine and to observe standard precaution. There is no post-exposure prophylaxis or vaccination is available for hepatitis C. Regarding HIV prophylaxis, when indicated, should be initiated as soon as possible following exposure, and ideally there should be no delay later than 24 hours. Our pharmacies should have hepatitis B vaccine, hepatitis B immunoglobulin, and HIV HIV antiretroviral agents available at all times. Lifetime risk factors for the source patient include high risk sexual behavior, intravenous drug use, tattooing, blood body fluid products before 1990, blood derived coagulation products before 1985, origin in developing countries, and dialysis. Now, what are the real approach, or what are the actual procedures we should carry out in after the exposure of these injuries? First is the first aid. What first aid should be given to healthcare provider? For percutaneous injuries, allow the site to bleed, wash regularly with soap and water, cleanse with alcohol wipes, cover with appropriate bandage like Sunnyplast. Regarding mucocutaneous exposure to body fluid exposure, remove contaminated clothing, irrigate affected area with a sufficient amount of water within 10 minutes. Then the next step is the reporting of injury. As I already explained that these injuries should be immediately reported. The employee should report the incident to their supervisor and document the incident report. The incident report includes the time and date of incident, location, department of employee, ID number, description of incident to include first aid measures. The report should be signed by supervisor, a copy sent to the infection control as well. This is about the counseling of the employees after exposure to viral hepatitis and HIV. The healthcare provider should refrain from donating blood, semen, plasma, or tissues to other patients. Pregnant or lactating women should be advised against breastfeeding. Personal items such as toothbrush, razors should not be shared. Sexual intercourse should be protected. What should be the basic serology for the source patient after an accident exposure? The baseline serology on the source patient after obtaining consent or counseling includes the testing of hepatitis B surface antigen, testing of anti-HCV, and testing of anti-HIV. This table shows the testing of exposed employees where follow-up is indicated. For example, when the source is positive for hepatitis B, C, or HIV, or source is unknown. For hepatitis B, the baseline test will be testing of hepatitis B surface antigen and anti-hepatitis B surface antigen. Yani antibody to hepatitis B surface antigen in the baseline. Then for hepatitis C, baseline test will be testing of anti-HCV and testing of ALT. In case of HIV, the baseline testing will be for the testing of HIV, for HIV. After 6 weeks, there is no need of HBsAg testing, anti-HBs testing, or anti-HCV or ALT testing. At 6 weeks, we should test anti-HIV status. After 3 months, there is no need of testing of HBsAg, and anti-HCV should be tested, ALT should not be tested, and at the 3 months, there should be testing of anti-HIV. 6 months after the exposure, we should test almost all these what we have tested on the baseline, namely the HBsAg, anti-HBs, anti-HCV, ALT, and anti-HIV. This is slide just showing the interpretation of pattern of hepatitis B virus serological markers I will mention only the few ones. For example, in acute cases, there is HBsAg positive, all other tests are negative. Acute resolving infection, HBsAg is positive, anti-HBC is positive, and IgM anti-HBC is positive, while anti-HBs is negative. In past infection, then total anti-HBC is positive and anti-HBs is also positive. Other two tests are negative. In chronic infections, HBsAg is positive and total anti-HBC is also positive. The remaining two tests will be negative. If the patient is immune, then the HBsAg will be negative, anti-HBC will be negative, IgM anti-HBC will be negative. The only test will be positive will be the anti-HBs. This is very important table. This shows all the management of hepatitis B after the exposure. In the column number 1, it is about the vaccination status of the healthcare provider. Mean if it is unvaccinated, it is responder, it is non-responders, or antibody response is not known for healthcare provider. For unvaccinated cases, if source patient is positive for HBs positive, then HBs antigen is positive, then we have to offer this healthcare provider one injection of hepatitis B immunoglobulin, and we will advise him to initiate hepatitis B vaccine. But if the source patient is negative for HBs antigen, then no need of hepatitis B immunoglobulin. Only that healthcare provider is advised to start hepatitis B vaccine and should get the 3 courses of 3 doses of this vaccine. But if source is unknown or not available for testing, then initiate hepatitis B vaccine series. Our healthcare provider is non-responder. Then in case of source that is positive for hepatitis B surface antigen, no treatment is required. If source patient is negative for hepatitis B antigen, again no treatment is required. If unknown status, there is no treatment is required. But if the source, if our healthcare provider is known non-responder, as I already explained, non-responders are those that have a anti-HBs titer less than 10 international units. Then, in case of non-responders, if source is positive for hepatitis B surface antigen, then one approach is that give immunoglobulin and initiate again revaccinate him or her. Second approach is this, that give him 2 injections of immunoglobulins. If a healthcare provider is known non-responder, mean ke his or her anti-HBs titer is less than 10 international unit per ml. Then there are 2 approaches. One is that we should offer him immunoglobulin with vaccination, and second approach is give him 2 injections of immunoglobulin, that is 1 month apart. If the source is HBs negative, there is no need of treatment. If source is unknown or not available for the testing, then what we should do, if known high risk source, treat it this as if source were HBsAg positive, test exposed person for anti-HBs. Now the last approach is that if the antibody response is not known for healthcare provider, then for source positive patients, source positive for hepatitis B surface antigen, if it is responder, mean her status, anti-HBs status is satisfactory, no treatment is necessary. But if it is inadequate, it is antibody titer is not satisfactory, then offer him hepatitis B immunoglobulin and initiate the vaccine or give him the vaccine booster. If the source is unknown or not available for testing, then if inadequate, then administer vaccine booster and recheck titer in 1 to 2 months. Sometimes there are queries about the vaccination or immunoglobulin given to the during the pregnancy. Hepatitis B virus infection during pregnancy might result in severe disease for mother and chronic infection for newborn. Therefore, neither pregnancy nor lactation should be considered a contraindication to vaccination of women. Immunoglobulin is not contraindicated for pregnant or lactated women. It means if there is accidental exposure of a pregnant woman, then we should offer them the vaccine and immunoglobulin as well according to the schedules. Now there are a few definitions are very much important before going to actual management table of HIV. HIV positive class 1 mean asymptomatic HIV infection or known low viral load. HIV positive class 2 mean symptomatic HIV infection, acquired immunodeficiency syndrome or known high viral load. The source of unknown HIV status mean disease source person with no samples available for HIV testing. Unknown source mean a needle from a sharps disposal container where source patient is not known. Less severe mean small needles or superficial injuries. More severe mean large bore needles and deep punctures. Large volume mean the exposure to the splashes. Small volume mean exposure to the few drops. After this definition, we have to actually use this table for actual management of exposure of HIV. First two columns shows the percutaneous and mucomembranous exposure of percutaneous mean less severe or more severe, and mucous membrane exposure is of small volume mean of few drops or large volume mean large splashes. Then what should be the plan for HIV positive exposure prophylaxis according to type of exposure and the source of the status, according to the infectious status of the source patient. If source patient is HIV positive class 1, then for less severe and small volume, basic true drugs of PPs for HIV are recommended. If the exposure is more severe and or large volume, then HIV positive class 1 source, 3 medicines are recommended for the PPs. Similarly, if HIV positive class 2 mean the patient is highly symptomatic, patient comes with AIDS or high viral load, then for less severe and small volume, 3 drugs are recommended. If and for the severe and large volume cases, the recommended again the 3 drugs are recommended for the HIV positive class 2 cases. Now the source is if source of unknown HIV, as I have defined earlier, generally no PPs for less severe and small volume. However, consider basic 2 drug PPs for source with HIV risk factors. But for more severe cases and large volumes, if the source of unknown HIV status, then again Generally, no PPs are required. However, consider basic 2-drug PPs for source with HIV risk factors. If the source is unknown, then for less severe and small volume injury exposure, generally no PPs are necessary. However, consider basic 2-drug PP in settings where exposure to HIV infected person is likely. But for more severe and large volume cases, in case of unknown source, generally no PP necessary. However, consider basic 2-drug PP in settings where exposure to HIV infected person is likely. And lastly, for HIV negative cases, definitely no PPs are required for less severe small volume and more severe large volume exposures. How we can prevent these needle stick injuries? Only following the infection control prevention recommendations and some precautions that are very much important. Avoid to use needles where safe and effective alternatives are available. Avoid recapping of needles. Mostly it has been seen that these injuries occurred while recapping of these used needles. Plan for safe handling and disposal before beginning of any procedure using the needles. Dispose of used needles promptly in appropriate sharp disposal containers. Report all needle stick and other sharp related injuries promptly to ensure that you receive appropriate follow-up care. Participate in blood-borne pathogen training and follow-up recommended infection prevention practices, including hepatitis B vaccine. Thank you so much for patient listening.